We are unmuted.
All
And
right.
there's Dr. Rob. Oh, let me turn those names off. There we go. Okay. It's time for the healthcare cheer, everyone. 7 o'clock. There's some noise. And I think we should hear my neighbor kids pretty quick. They love the excuse to make noise. No?
Hello, everybody. Welcome to Viral Transmissions. Some ships in the harbor even pulling on their horns tonight.
Oh, I can't hear it. Damn it, that Discord noise cancellation.
So I got to keep talking for you to hear the cheering?
I think so.
Okay. So we're standing on a balcony here overlooking False Creek, which is an inland saltwater creek in Vancouver. And the noise you're hearing in the background are all the folks. So there's a little kid across the way who always waves at us. Mom's trying to get him to wave. I think you see he's on camera and he's shy. But he's there. He's cheering. Hey, we got folks waving at each other across balconies tonight. That's a little unusual.
Okay.
Don't see that too often. I guess we're getting to know each other sort of after a couple of months of doing this. Yeah.
My neighbor kids have grabbed their pots and pans.
Yeah. Oh, yeah, we got pots, pans. There's a tambourine right there. There's, I'm not sure what, but that seems to be, it's either a pot or some kind of musical instrument, but it tinkles in a way that a pot really wouldn't tinkle.
Yeah.
And lots of folks who are just clapping. That person over there waving, they're actually holding a shaker. We thought initially they were just waving. And so we started referring to them informally as the royal family because they stand on the balcony and wave. But it looks like the cheer's winding down. And it's time for me to head back inside and we'll get the show started.
All right. So while you head in, oh, damn. Dropped away and my names don't make sense anymore. There we go. Wait for Rob to get back in. To dead air. This is great live streaming. Well, I'll just do the welcome. Rob will be here soon. Greetings, guys, gals, and non-binary pals. I'm Joe Foljam. Welcome to Viral Transmissions, episode number 8. We've done it 2 full months now. Joining me as usual are Dr. Rob Tarswell, who should be just popping in there. He is right there. And Torrin Atkinson. Our guest tonight is Dr. Gregory Rose, who is a community-based infectious diseases specialist and infection control consultant in Ottawa. For those of you who don't know Canada that well, that is the capital of Canada. So it's a big deal city, politically at least. I'd like to note that Viral Transmissions is supported in part by the BC Humanist Association. You can learn more about them at bchumanist.ca, and we thank them very much for their support. All right, I will hand it over to Dr. Rob, who knows Dr. Rose fairly well. Take it away, Rob.
Yeah, so just by way of background, Dr. Rose and I went to medical school together, so we've known each other 23 years, if you can believe it. It doesn't really feel that long. But anyway, yeah. So both proud alums of the University of Manitoba School of Medicine. Greg went on to internal medicine and then infectious disease when I went off to psychiatry and then nuclear medicine. So we thought it'd be interesting to get the clinical perspective, particularly from somebody who's not only in infectious disease, but specifically in infection control, which has been a major concern with the virus since we don't really have any pharmacological treatment. All our interventions are non-pharmacological, and the backstop of that is infection control. And with that, why don't you explain to us what infection control is and what it involves?
Absolutely. Thank you very much. So infection control is essentially the same kinds of principles that are used on the public basis, on a widespread basis by public health, but applied inside healthcare settings. Hospitals, certainly, and that's where I mostly do my IPAC, infection prevention and control is called IPAC, so I'll probably be dropping that a lot tonight. I do most of my IPAC work at a small community hospital in Ottawa called the Queensway Carleton, 300-bed facility with multiple different specialties. I've also done some work at a larger teaching hospital here in town as well. Infection control can also include things like developing policies that are applied in long-term care facilities and step-down facilities and the like. But basically, public health type activities occurring within the healthcare setting is infection control. It's often one of those things that people get into more or less by accident. Although in infectious diseases, it's considered to be a more or less standard career path for a small section of people. My specialty, infectious diseases, or specifically in adults, is often dominated by things like treatment of HIV and viral hepatitis and other diseases like that. But quality-based programmatic kind of stuff like infection control and stewardship of antibiotics to try and reduce overuse are becoming increasingly popular.
What can you tell us now? I remember you had a brief splash of fame because I think it was in Ottawa, and I think it was members of your team or people that you knew who set up Canada's first drive-through coronavirus testing facility.
Yeah, I actually got myself
in early March.
It's still cold here in Ottawa right now. We're down less than 3 degrees centigrade, and it was snowing the last couple of days, which is a real kick in the teeth because it was actually sunny and spring-like earlier this week. Yeah, I got myself in a bit of trouble with a tweet there in early March. I was extremely proud of the innovation in my team. We had been having an increasing surge in the number of patients seeking testing for COVID in early March. And this was back before Ontario changed its recommendations on the management of people with suspected COVID. In February and into the early part of March, every single person who potentially had COVID had to be managed with an infection control policy based around the idea that they might be generating airborne virus, which is to say tiny little particles of virus that can spread long distances in nonlinear patterns and follow air currents from one room to another, and which have to be dealt with by having the patient in a very specialized environment and having the healthcare workers dealing with that patient wearing the famous N95 mask, or N95 respirator to give it its proper name. We were getting to the point where the number of patients coming in looking for testing was exceeding our ability to actually see them within a 24-hour period because we had a limited number of rooms inside our emergency department that we could put onto negative pressure, which is to say a lower pressure inside the room than outside the room. So if you open the door, air gets sucked in and viruses can't escape. We had a limited number of rooms and we couldn't see them all within a 24-hour period. We had been experimenting with the idea of taking a portable shelter and setting it up, but we actually kind of hit a crisis point one particular day as 70 patients were referred to our emergency department in one afternoon to be tested. To put perspective on that, our emergency department typically sees about 200 people a day in a 24-hour period for all different types of problems. So to have 70 people show up in one afternoon for testing and require this very, very specialized equipment and very, very specialized environment was a tall order. So yeah, we moved our testing table out to the driveway just outside our main entrance. So patients would come in, they would check at the registry desk. They would say, "Yeah, I'm here because I have a cough or a fever or shortness of breath, and I think I need to be tested for COVID." They would be then sent back out to their cars to circle after checking to make sure that they were well enough to do this. They would be sent back out to their cars. They would circle around, and a team of a doctor and 2 to 3 nurses would take the clinical information and take the sample. Now, this was a rousing success just from the point of view of the problem it was fixing, which was, this huge backlog. By the next morning, all of the patients that had been sent to us had been tested and been sent home happily, and none of them actually wound up being positive. But because of the incredible fortitude of my teammates, who were out there in the cold at dusk with temperatures hovering around zero and cars zipping past them, unfortunately not in a necessarily safe fashion, I felt so proud. I put this text out, I put this tweet out about that, and the next morning I came to work to find a lineup of 200 cars outside the emergency room, expecting that they would be able to just drive through and get their tests done.
Oh, wow.
As you might imagine, an organization the size of a hospital has an entire media group, and I was given the very kindly advice that I need to check with them before I tweet again.
You got your hands slapped.
Fired you on the spot and put you in charge. You put your hospital on the map.
Well, actually, I'm still getting people who are following me on Twitter because of that, and I think they're actually probably going to be disappointed to find that most of the very few tweets I've done over the years have either been related to medical politics. I'm involved in the Ontario Medical Association, or more commonly, rugby.
Actually, for rugby.
I'm sure
So
they will complain about that. I'm familiar with Twitter, and that seems to be the thing. Stop talking about the thing I don't want you to talk about.
Well,
yeah.
up until now, most of my Twitter followers have been confused people looking for a more famous Dr. Gregory Rose, who's a golf guru in the United States. So
Oh,
You should start
wow.
giving
I'm
out
used to
golf
it.
advice.
You
See what
hit the
happens.
ball with the stick thing. I'm not really sure. I know there's drinking involved, and that's
I mean, it is a Scottish sport.
Just say
Greg.
use the 9-iron. Always the 9-iron.
I'm going to do that from now on.
So now you mentioned just before the broadcast that there's just been a recent change in your hospital's infection status. Tell us a bit about that.
Well, we started getting patients coming through our emergency department that became positive. By around the second or third week of March, we were having a few people relatively well. Around that time, we actually had started to put the work in to create an external to our hospital assessment center where we could actually have people who were at higher likelihood of having COVID. So we'd actually, again, these incredibly innovative things my hospital has been doing, and in all fairness, although I'm an infection control and infection prevention fellow, a lot of the work is being done by the emergency department at my hospital. They set up this external assessment center, which started seeing people and seeing something in the area of, again, about 80 to 100 a day, which is almost as many at that point as they were seeing through the emergency department. We started to see higher and higher numbers of people needing to be admitted, and specifically people needing to be admitted to the intensive care unit. Ottawa is a geographically strange city, and actually there is a difference in the average age from one end of the city to the other. We're in the part of town where there's a higher average age, and as a result, we actually had a higher number of elderly people requiring admission. In fact, over the outbreak in my city, at least in the last 2 months, of 4 adult hospitals, so 2 teaching hospitals and 2 community-based hospitals, my hospital has seen 40% of the admissions. And it was actually quite hectic there in early April, and started to tail off towards the end of April to the point where we were starting to hope that we might see the curve truly flatten. And this is when the true scope of the problem made itself apparent. And the true scope of the problem, at least in the Canadian context and certainly in the Ontario context, is that COVID-19 is a disease that is disproportionately hitting our long-term care facilities. This was actually starting to become quite evident even 4 weeks ago when the numbers are updated on a daily basis by Public Health Ontario. And we had hit something, a watershed of, I believe it was 39 institutions across the province on outbreak. Of the healthcare workers in our province who have been infected, well over half were infected in a long-term care facility. We had, at that point, there was one quite famous outbreak in cottage country with the majority of the residents of one particular long-term care facility becoming ill and 21 of them dying in a very short period of time. So a very tragic and heartbreaking situation, compounded, I will say, by the long-term institutional problems with long-term care facility delivery, healthcare delivery in Ontario and frankly in Canada. It's kind of the perfect storm in Canada. I mean, COVID-19 is a disease that disproportionately attacks older people, and it disproportionately causes poor outcomes, including death in older people, particularly older people with other diseases like cancer or diabetes or heart disease. So to take a population of people that are at higher likelihood of having a poor outcome, and then having a number of other hurdles in the long-term care facility milieu, amongst other things, we spent a lot of time in March. We, the Royal We, Infection Control and Public Health as well, spent a lot of time in March making sure we were prepared. We had our lines drawn. We had We knew we had problems getting personal protective equipment. We knew we had problems getting diagnostic equipment. We knew that there weren't any, at that time, and frankly even still now, no known effective therapies. There were shortages on things like ventilators, and we spent all of March preparing for that because we knew that wave was coming. And we were actually, by early April, relatively well prepared, and that's when it became apparent that while we were stocking up on personal protective equipment, there really wasn't enough that the long-term care facilities could also be stocking up on personal protective equipment. So there was massive shortages of key pieces of equipment: gloves, hand sanitizer, gowns to keep the clothing from getting contaminated, and most importantly, procedure masks, fluid-resistant procedure masks to keep healthcare workers from themselves acquiring the disease and being able to spread it to others. Massive shortages. On top of longer-standing issues that aren't even particularly related to COVID. The long-term care facilities are not, in Ontario at least, not governed by the same ministry as healthcare facilities like hospitals and step-down facilities. And there's a greater degree of variation from one facility to another in terms of their in terms of their infection control policies, as well as their occupational health policies, which is the branch of administrative work that deals with keeping healthcare workers from acquiring illness, including infections, while at work. There was a massive issue, and still is a massive issue, with an essentially permanently part-time labor force. There are a number of reasons for that, and I'm not really going to delve into how this came to be, but the truth of the matter is the vast majority of workers in long-term care facilities in Ontario work at 3 or more facilities because they don't get full-time hours in any one particular facility. And what this meant was if you were in home A and you picked up COVID, you had a shift the next day in home B. You didn't have appropriate protective equipment in either one of those, and you are now the vector spreading this from place to place.
Oh, man.
So in the second week of April, actually, the provincial government issued a directive stating that long-term care facility workers had to choose one place of employment for at least the foreseeable future. My personal hope is that this becomes the new normal. Although this is the very start of a long and fairly challenging period in human history, I'm a big believer that challenges like this often lead to social benefits as well, obviously, as tragedy and heartbreak. And one of the social benefits I see perhaps is a fairer deal in the future for long-term care facility workers as well as residents. So yes, I've strayed off topic as I always do. Long-term care facilities have become the focus of spread, unfortunately, in Ontario, and as a result, our numbers have actually started to increase in my hospital as we're seeing larger and larger numbers of people coming in with LTC with LTC-acquired infections.
Rob, we had that in BC, right? That are again the workers at the facilities were jumping between them, and then I'm pretty sure our provincial health care said stop doing that and stick to one after they noticed what was going on.
We basically ordered our long-term care workers to work at one facility only, and since basically, I think this is similar in Ontario, but once a provincial health emergency has been declared, our provincial health officer essentially acts as a mini sovereign in terms of medical orders that are issued, and those have the compelling power of law unless overturned by an act of the legislature. And so as soon as she orders that, then the government has to respond to that order and come up with the money to make it happen, which they did. So far, there's been really tight, excellent coordination between the Ministry of Health, the Premier's office, and the Provincial Health Office, which is just an absolute stroke of good luck for BC. And I think for the most part in Ontario, that's been the case as well. I've been really pleasantly surprised by how rapidly the Ford administration just kind of got on the "this is Team Canada" train and has been, at least from an outsider's perspective, doing okay. But at the bigger level, you mentioned that this is we're at the very beginning of a global challenge, if I may paraphrase you. And this is something that you've been following as well, is what's been happening with your eyes as an infectious disease specialist Can you kind of walk us through some of your observations at that kind of global level on down?
Well, whenever we talk about a pandemic, in truth, we're talking about a series of epidemics, and each epidemic geographically is its own beast, and they vary from country to country. They vary from province to province, and amongst other jurisdictions as well. And because of that, you see different flavors and different problems cropping up. I would say that the origin of the pandemic in Wuhan, China, you had some of the inherent perhaps weaknesses of a political structure where mistakes are intolerable and severely punished, which has unfortunately the knock-on effect of meaning that mistakes, rather than being addressed head-on, are sometimes ignored in the hopes that they would go away.
Yeah,
This
they're just not reported.
Yeah, exactly. It allowed propagation in the early days of the pandemic. We really still don't have a very good grip on exactly when this started. I suspect it was probably early November. That just this week, of course, we have evidence that there are people in France who had unexplained respiratory infections over the Christmas period, who actually turned out to have had COVID. So
Oh, wow.
You already had exportation of virus before we were even aware of it. Now, I personally became aware of it, I think it was January 2nd or 3rd, because they talked about, a handful of cases of this severe infection in Wuhan. Now, I wasn't in practice in 2003 during SARS, but, I was in infectious disease training, and boy, oh boy, I remember those days. So it immediately triggered for me. I thought at first, as many people did, that this was going to be a controllable problem. But by the third week of January, when China locked down Wuhan and the entirety of Hebei province, and we were starting to see these estimates of what the RNA, the reproductive rate, was, it became very apparent to me that we were going to have this infection. I knew it was coming at that point. And it did. I wouldn't have guessed that Italy would be the next locus of it. But Italy, you had different problems yet again. In Italy, you had multiple importation of probably at least 2 different strains of COVID. In fact, I'm not an expert on the genomics of the virus. I do think actually that there's something in the area of 6 or more different distinctive strains that have now been described. And you had widespread in a population of relatively healthy but older people in probably one of the best developed medical systems in the OECD. And it almost destroyed the medical infrastructure of northern Italy, the industrial heartland and the richest part of Italy. That was sobering. And it became very apparent then, if it wasn't already, that a serious response was required. We have been extremely lucky in Canada that we had essentially until the second week of March before we really started to face problems. I think, unfortunately, given the already stretched resources of our medical system, if we had been at the thin edge of the wedge in late January or early February, I do think we would have had a much different experience over the last few months. But again, it is only the first few months. In Canada, there have been, and by the way, I'm not sure if there's a way of sharing URLs, but I've got a couple of favorite sites that I like to go to, including one where data are presented by a Public Health Agency of Canada, showing the Canada-wide numbers as well as a province or territory basis, including what we call the epidemiologic curves, which is to say the chart showing acquisition of cases over time. We have 68,000.
Are you on the Twitch? Or if not, we could put you... Okay, you can just put them directly into the Twitch chat if you want.
I'm on the Discord.
Or put them into Discord, into our chat, and we can put them over into Twitch.
I'll put them out on Twitch. I am way too middle-aged. I'm going to put a very famous one people already most likely have, which is the Johns Hopkins Geographic Information Surveillance maps, and then the PHAC. So yeah, we have 68,000 cases in Canada that we know of. Those are confirmed cases. Now there are some estimates that, for example, in California and New York, there may be something in the area of 50 cases that aren't diagnosed for every one that we know about. So let's go with that number. There's 50 people that we don't know about for every one that we do. Out of 68,000, we're looking at something in the area of 3.5 million Canadians may have COVID. That's obviously a very big outbreak. Or may
It's
have
huge.
or have had. It's huge, except it's 10% of our population, which is to say 90% of our population has not had COVID. Now, even presuming, and honestly, it is still an unknown, even presuming there is such thing as complete immunity to COVID, whether that be in the short term or the long term, 90% of Canadians do not have it. Herd immunity starts when you have 70% of the population immune to a particular infection. We have 10% at most. As far as the virus is concerned, Canada is no different today than it was in early February. We are ripe for the plucking, as is most of the world, as far as we know. There are parts of New York State, I believe, where the seroprevalence, the evidence of immunity in the blood, is 40% or more, and those are looking good. Those numbers, they're on track to maybe achieving something like herd immunity if they allow their outbreak to spread rapidly again. But we are nowhere near that level. And actually, I'm going to digress, as I, again, always do. If you think about that, you think of the horror that New York State has gone through in the last month and a half. To have, at most, something in the area of 40% of their people immune and potentially protected against this virus, it shows to me that the idea of let's just rip the Band-Aid off, get it over with, loosen social distancing, allow everyone to get sick, and just we'll be done this infection in a matter of a month or so. It's not going to happen. Even uncontrolled, it takes time for a virus to work its way through a population. And when it is uncontrolled, as we saw in New York, it overwhelms healthcare systems, even a very, very wealthy healthcare system like the United States.
Yeah. As somebody who's not an expert like yourself, I don't know what it is about me that maybe I just understand math and a lot of people don't get that. But like when you talk about that 40% already potentially having the immunity and that still not being enough, like, I mean, that I felt that way the whole time, and I still can't understand that people who are in power and are being advised by people like yourself about these pretty easy to understand numbers. We're not talking about calculus here. We're just talking about you got to have 70%. New York itself has 40%. Most of the other places have way less. You can't open up. And those people in power are still saying, well, we got to open up. And I cannot connect those truths together. I don't know how their thinking works, that they're like, I don't know what the drive is to do this besides not caring about human life. That's the only explanation I can come up with.
If I can
But Joe, don't you know if we don't open up the economy, other people might die? People die every day. Didn't you hear? That's a medical fact.
I have seen some people say suicides are on the rise, so we have to open up. And I'm like, do you have any numbers? Like,
right.
It cannot I believe you. I believe you that people are being pushed more into depression, and it's a greater risk factor. But it cannot possibly match the number of people that are going to be harmed by a COVID outbreak. Like, people. Anyway, I'm sorry. I have no question for you. I just have exasperation to share. That's all.
In 1932, at the height of the Great Depression, suicides never exceeded 1 in 5,000. Okay. At present, about 1 in 500 New Yorkers are dead from the first epidemic wave of COVID.
So 10 times as many as would be from a peak suicide. Okay. See, and that's a number that, again, people in power should know, that people who operate media should be getting out, things like that. And instead we're getting disinformation all over the place, which I'm sorry, it's not Dr. Rose's area of expertise, but it's just the thing that I'm frustrated
expertise
about.
No, but concern, definitely.
Yeah, absolutely. I'm glad that you
grabbed the shillelagh from you there, Greg. Sorry.
No. I mean, on that exact same topic, the current numbers in the United States are about 1,500 people dying every day, which is to say 9/11 every 2 days.
Yeah.
And that's at the tail end of the New York outbreak, the tail end of the first wave, with more waves, unfortunately, yet to come. And they're talking about loosening. Honestly, it beggars belief. 19 years after 9/11, we are still taking off our belts and shoes at the airport and checking our bottles of water. And we're talking about, 2 months is too long for the economy to be on pause because of this. It is either callousness, which is entirely possible, or, and it's strange to say this, but I hope, I'm not a psychologist, but I hope what it truly is an inability to digest the stark truth of what we're facing here.
Mm-hmm.
And we're facing a challenge that we have not seen in 100 years, and we're facing it more or less with the same tools we had 100 years ago. Because for all of our, our ventilators and our CT scans and our, better approach to certain basics like managing, feeding people who are unable to feed themselves and the like, our actual treatments for this consist of watchful waiting and tincture of time.
I hope that you are right about that, because the I guess self-denial that you're kind of hoping it is. I hope it's that, because that's the thing you can overcome. But if it's callousness, I don't think we're ever going to change people's minds about that. They're just never going to care. So I really do hope that it's just a quirk of being human and refusing or being unable to handle that info, because eventually they're going to have to.
Yeah. From one of our frontline workers who has been in the center of the New York wave, ischemia. I can speak to that a bit. I have a coworker at our crisis/suicide hotline, and we get a lot of calls about crisis, but not many are actually suicidal, just very scared.
I join them. I don't know. I mean, we're living. I'm sure everybody who is even partway experiences anxiety is even more heightened now, just from the inability to know where we're going to be in a month, like or 2 months or the end of the year. Like
especially with people's jobs and trying to get some kind of income.
Yeah. I hope that, again, though, that's another healthcare crisis, I'm sure, that's just going to grow as time goes on. Is they're going to need people like Dr. Rob here to help them get through these tough times. And I, again, also not an expert. I don't know what the answer is. I don't know. Come join us and play some Jackbox games after we're done. That's what you should do. We're going to play at 8:30 after this is done. Join
Wash
my
your
Discord
hands.
server.
Wash your filthy hands.
And yes, wash your hands.
I was wondering what exactly defines an outbreak. Like, what are the numbers in a hospital?
Oh, okay. Very good question, actually, because the second part is the best part of that question, because an outbreak is actually quite variable depending on what exactly you're talking about. If it's a relatively common thing, for example, in infection control, we in addition to dealing with big, scary organisms like SARS and drug-resistant bacteria, we also deal with complications of treatment. So sometimes when we put a catheter in to drain somebody's bladder, and we leave that in place, that catheter can allow bacteria into the bladder and cause a urinary tract infection. And specifically, it's called a catheter-associated urinary tract infection. These are incredibly common. You would need to have a large number of them, or have a number of them associated with a very strange bacteria in order to call that an outbreak, because we see it so often, it's not really going to trigger anybody.
It's just business as usual.
Business as usual, unless there's something funny about it, like they're particularly severe, or there's a really unusual number. And normally that's defined with statistics. In everything in epidemiology, and infection control is essentially a branch. In fact, when we want to feel pompous, we call ourselves healthcare epidemiologists. Everything in epidemiology is more or less governed by Fisherian statistics, unless you're one of those Bayesian people that own MacBooks before MacBooks were cool. That's a joke for my epi homies. You don't need to laugh. It's okay. So basically, if you're 2 standard deviations away from your normal mean, so if you think of a bell curve, if your mean is right in the center, if you're down towards the tail at the right-hand side of your chart, that's going to be an outbreak. For something like COVID or any other really very, very highly important disease like this, a single case is an outbreak.
Okay.
So acquisition of even a single case in hospital by a patient or by a healthcare worker would be considered an outbreak. And indeed, the number of outbreaks we've had in Ontario, quite a lot of the hospital-based outbreaks have been one or maybe two people who have gotten sick. We haven't had large-scale outbreaks in hospital. Unfortunately, we have had large-scale outbreaks in many of our long-term care facilities.
Mm-hmm.
There are long-term care facilities in Ontario where north of 60% of the residents actually have acquired COVID. And surprisingly, actually, many of them are quite well. You know, the only reason we even know they have it is because one of the rules that was created by our provincial government in response to the crisis as it evolves is that if you get a case in a long-term care facility, you test every resident in that facility.
Right.
Which is really good to have. Unfortunately, it's something we have to be fairly careful about because our ability to test is still quite limited. The standard test, as available in Canada for COVID, is something called a PCR. So this is a test where we're checking for the actual genes of the virus and some or other sample, typically a swab from the nose or a swab from the mouth. These swabs are a very particular type of rayon that have to be sent in a very particular liquid called universal transport medium, or up until relatively recently had to be sent in this liquid called universal transport medium. Most of the universal transport media in the world is made in Milan, Italy, which you will recognize as a place that has had some problems lately.
Right.
So, in fact, we actually have not had the supply to be able to test to the degree that we would like. And in fact, what many labs have had to do is they've started to look to other liquids to try and keep the sample from drying out and being no good anymore. So we've gone kind of to second and third choice options, including just sterile salt water in order to transport these. And even with that, there's fairly limited numbers Canada-wide and frankly worldwide. Some places had a better pre-existing stock than others. Which the irony here is, normally in medicine, when there's a difficulty getting a particular test done, it's because the lab doesn't have the ability to do it. But our labs are absolutely roaring. They can process thousands and thousands of samples a day, but the actual availability of the stock to do these samples is very closely guarded. And this is one of the big frustrations many people on the front lines have had over the last 2 months, is because the recommendations have been trying to achieve this very fine balance between safeguarding very, very scarce supply and making sure we're testing enough people. So there's been changes on an almost twice a week basis, some weeks, in terms of who is to be tested and how many tests that I have done and what type of, samples that they're having done. But testing widespread, like we've done in long-term care facilities, would be absolutely marvelous if we could do it on a population basis. We're not anywhere near ready for that, unfortunately.
If you had to guess, when will we be close, if ever?
I really had my heart set on point-of-care PCR testing, so testing for the genes of the virus with a handheld machine that can be used in a clinic. In fact, there's a company here in Ottawa, well, technically Canada, which is kind of Silicon Valley of the Ottawa Valley, called Spartan Biosciences, which developed a very useful-looking test that was actually licensed on the 13th of April, and then unfortunately withdrawn voluntarily last week because there were questions about the degree of testing that not on the test. And that's an awful lot of use of the word testing. There were questions about the swabs that they were using because they were actually their own creation and they hadn't been fully evaluated yet by Health Canada. I'm hoping to see that they'll be coming back to market very shortly because I do think that is going to be the best way of ensuring we have large amounts of test kits available across Canada, would be those handheld ones. There's a second type of test which can be used for looking for the COVID virus, and that's looking for an immune response to the COVID virus, or a serology, that's called. Serology has a bit more of a different flavor to what it's used for. We do the PCR test to look to see whether there's active virus, or at least there's portions of active virus in the patient. Serology is more or less looking to see whether the patient has developed an immune response, and that often occurs 2 weeks later than the PCR. So there's kind of a window in between, perhaps. The serology tests have not yet licensed in Canada, and I think they will be very, very useful, not so much for diagnosing people who actively have symptoms, but more for looking to see if people have recovered and had COVID. It'll also be a good idea of getting an idea of exactly how widespread this truly has been.
Yeah, and then know how close we are to that 70%, which I kind of hope that we never do, honestly, or at least naturally. I hope we don't hit 70%. I hope we hit 70% with a vaccine. Yeah, let's do it with vaccination. I'm willing to chill until that happens.
I hate to be pessimistic, although that is my nature. I'm not sure that we're going to have a vaccine that works as well as our standard vaccines do for other diseases.
Yeah.
The immunology of coronaviruses in general is extremely complex and quite what's the term I'm looking for? Idiosyncratic.
Mm-hmm.
There are 4 common coronaviruses that we've known about for at least 50 odd years, and they cause generally colds. Their causes a seasonal infectious rhinitis or colds, typically in waves that occur every 2 to 3 years. Now, we're used to that kind of picture with influenza. Every year we have a new influenza outbreak in every country, and that's because influenza actually mutates rapidly enough that it's a slightly different virus every year.
Mm-hmm.
But that's not what's going on with coronavirus. Every 2 to 3 years, more or less the exact same strains of these 4 different strains hit the human population and circulate around the world because immunity to them wears off.
Mm-hmm.
So there is a very, very big question mark as to whether or not there is such thing as permanent long-term immunity to coronaviruses, and there's all kinds of reasons why that might be. There's different parts of the immune system that get engaged with different infections and are used in that kind of long-term protection. We're used to thinking about serology, as I've mentioned. In serology, what we're talking about is the creation of proteins that are specific to the virus that float around and can attach to them and can help the body to clear and destroy the viruses. But there's also cells that are involved in destroying viruses. So there's cell-mediated immunity as well. And often that needs to be engaged in different types of infections. Typically, when you have that kind of situation, the kind of vaccines we need are vaccines that, instead of having a portion or a single protein from the virus, we need to have a mutated version of the virus that's incapable of causing disease. The most famous example of that is the measles, mumps, rubella vaccine. The measles, mumps, rubella vaccine is 3 different live viruses, mutated, weakened versions of measles, mumps, and rubella. And the reason why we need that is we need to engage cell-mediated immunity. Interestingly, the only commercially available mammalian vaccine for a coronavirus is a veterinary vaccine for an infection in cats called feline infectious peritonitis. And the development story of that honestly gives me some cause for concern about the possibility of a successful vaccine. Now, again, I'm not a vaccinologist, and I think you actually have had a virologist a couple times on your program who could definitely comment on this with a greater degree of precision. But the story with the feline infectious peritonitis vaccine is a bit worrisome. It had been worked on for decades. Inactivated virus vaccines, so where they take just one protein from the virus and they give it to the cat, actually did not prevent cats from acquiring the infection. And when they did acquire the infection, it was worse and more severe than if they had never been vaccinated in the first place. It wasn't until they invented a live attenuated virus vaccine that they got a vaccine that wasn't actively killing the cats quicker. And even that vaccine, although it is licensed and it is on the market, it's not terribly effective. And most vets will tell you they do not actually prescribe it. So I am very concerned that our standard approaches to vaccine development might not be sufficient to give us even short-term immunity. And maybe short-term is all we need. Maybe what we need is, if we could rapidly roll out 7 billion doses of vaccine and hit everyone in the world in the space of a couple of months, we could stop this infection.
Right.
And it wouldn't matter at that point if your immunity wears off 2 years down the line, if we get rid of it right away. But that's still a big if.
Yeah.
I'm going to be honest. Go ahead. Sorry.
We had Dr. Van Houten on a couple of times on our last episode. She talked about a vaccine that is exciting her quite a bit, but noted that it's not an actual immunity vaccine. It's a vaccine that when you get it, the symptoms of the COVID-19 are supposed to be lessened, which I guess means you get it and hopefully less chance of mortality from getting it, which fine. I will still probably get the man cold much more brutally than most people. So I'm terrified of catching this. Yeah, cold Timmy hard. So please, everybody else get immune. I'm done for. Yeah, so, and it's the same thing also, and the timeline, like we have no idea how long it's going to take to test all this stuff. I absolutely understand that. But the idea of us rolling those mortality dice on a large percentage of our population is terrifying to me. I mean, I know that at my age, I'm at about 1.5%, right? I thought my asthma would make it bad, but it looks like asthma is not a pre-existing condition that makes it worse, but who knows? Who knows how I'll do? I'm a little scared. Yeah.
You've played enough D&D, you've hit a 0-0
Yeah.
more than once.
I've rolled a 0-1.
Right?
I've rolled a 0-1 on a percentile dice that I thought would completely pass. Yeah, absolutely. Or a 0-0, depending if you want high or low. Yeah. I don't like those odds. I'm not on my life. Thank you. No.
Yeah, right.
No.
That's scratching wins. That's the kind of odds you want. Scratching wins, not a fatal virus.
Yeah.
Lord.
Pass.
Speaking of which, Greg, could you touch on, because this is evolving as well, the clinical manifestations we're starting to understand to a greater degree. Can you touch on what some of the clinical manifestations are, the ones that have endured the test of time, whatever that means, 12, 16 weeks into this thing, and which ones strike you as sort of implausible or less likely?
So yeah, this is actually a really complex topic, to be perfectly honest with you. And part of it, our information is limited by confirmation bias. It's confirmation bias, meaning we've got information that tells us what we thought we knew, and therefore we believe it because it's telling us what we thought we knew. So, we geared up to battle what we call an acute respiratory infection, an ARI. An ARI is a standard definition for a type of infection. We've had it, it's really, with various different terms, it's been around for decades, but we've particularly focused on that term, ARI, since the SARS mini pandemic in 2003. And an ARI is shortness of breath, cough, and fever. And there's no doubt that this is a respiratory infection and it can cause shortness of breath and cough and fever. Even when we knew that was our classic picture back in January and February, we also knew that there was a large number of people who didn't have those classic symptoms. They had subclinical manifestations, which is to say they weren't that sick, or maybe they weren't sick at all. But we still were running under the assumption that fever, cough, and shortness of breath were the unholy trinity of what to look for with this infection. And because that's what we were looking for, we got studies coming back saying, yep, fever's present in 94% of patients, cough is present in like 60, 70% plus, shortness of breath in 50% plus. And then there's a whole laundry list of less common symptoms, including things a bit more typical of a common cold, like a runny nose or sore throat. And then weird stuff started happening. We got the initial couple of reports of people completely losing their sense of smell, and with it, their sense of taste, because smell really informs how you appreciate your food. And at first, that seemed like it was going to be some weird one-off, but then they started doing these broader studies, actively asking these questions in the Italian outbreak, and they found that actually, probably about 70% of people at some point or another in the course of illness will lose at least a portion of their sense of smell. And it's not because their noses are getting plugged up the way they would with, say, a sinusitis. There's no mucus up there. There's nothing in the sinuses. They just lose their sense of smell. We're not even really sure why that happens, although the current theory, because of some other new symptoms, is that perhaps the nerves that actually go from the brain, go from the lining of the nose to the brain to actually inform the brain of a sense of smell are actually being attacked directly, which is an interesting finding. And in fact, a lot of the new stuff you might have been hearing about over the last few weeks all seem to be in that broad category of secondary attack. So we've, very early on, there was a question about whether or not it could infect the gut. And it does appear to be able to infect the gut. Belly pain and diarrhea are well-described symptoms. COVID genes can be found in stool. They can be found in sewage effluent long after it's left the person. Now, we don't know that means that stool can cause infection, by the way. Because when we do a test for genes, that's not looking for a whole virus that's able to go into a cell and reproduce. It's just the genes. And the genes actually tend to survive long after the virus is dead. But it's definitely in the gut. And there's good reasons to think that could happen. And then over the last few weeks, we started to see these really unusual findings, strokes in young people. People having various forms of clot, not just in their brain, but in other parts of their body, including small clots in their hands and feet. Damage to the kidneys, damage to the liver, over and above what we'd expect. So backing the truck up to January, February, when what we were seeing was people coming in with severe infections coming into the intensive care unit. They had a condition that we call sepsis. Now, we know a fair amount about sepsis. Sepsis is you'll hear the term cytokine storm. It's basically an infection has affected the body to such a degree that the immune response to the infection is starting to go hog wild and causing damage to various organs. We've been dealing with sepsis as long as we've been doing medicine, and unfortunately, one of the things we've learned about sepsis over the years is there's not a whole lot you can do about it. Septic shock has a 50% mortality. And every single study of every single intervention we have ever tried to try and reduce the death rate from septic shock has not budged it from a 1 in 2 chance of dying. That's what we thought we were dealing with. But actually, as we start to get more and more autopsy data on people who have died of COVID, they're not dying of what looks to be classic septic shock. There's something else going on. So septic shock can damage the brain, septic shock can damage the liver, septic shock can damage the kidneys, but the damage happening in these patients is different. And it's still not clear why. One of the more common thoughts is that maybe people get really, really sticky blood and they're clotting off the small blood vessels in all these different organs. There may also be, and here's where we get a little bit further out onto the, I wouldn't say improbable, but less clearly linked scale. There might also be this syndrome where people, once they've recovered from the infection, they've got damage to various different organs because of their immune response to it. So the post-COVID inflammatory state. It's really interesting, and a lot of the data from this are coming out of UK. They're seeing strange diseases, odd damage to organs, and particularly rashes popping up in children. And these kids are not, for the most part, being positive on testing for COVID. But the thought is maybe they had COVID 2 or 3 weeks ago. The virus is no longer being cleared by the body, but they're having this inflammatory response after they've already recovered from the infection. This is being looked at actually fairly aggressively in a number of the centers that have had larger outbreaks, and the jury's still out, but it does suggest that this virus has specific ways of damaging us that other coronaviruses don't.
Wow. Yeah. I'd heard about the thickening of the blood or stickiness of the blood and the clotting and things like that, which reminds me of when we had Sasha Malecki on, who was a am I saying that right? Clinical pharmacist?
Yeah.
And was talking about, actually mentioned blood thinners as something that might be useful, but also they only have so much of them. And if they start having to use them for all the COVID people, all the people who need it for all sorts of other things are going to not have it available. So again, even if that becomes like a solution, it becomes another supply chain problem that we again have with this thing that has to get solved in order to handle that. The more we learn about this, I mean, you start mentioning all this other stuff, the bigger this becomes. And it feels like, again, bringing back to what you talked about before, hopefully something good will come out of this, and maybe that will be a more responsive, reactive healthcare system and drug production capability for all of humanity, so that we maybe as a people recognize that, like, figuring this out fast, getting the proper things made and getting them to the people is of vital importance to the entire world. And that includes the people who value the economy over life. Like, if we could somehow convince them that, hey, if we handle this fast, then you do get to go back to work faster and you get to keep making the money that you want. That a healthy economy requires a healthy people. Sorry, I got frustrated again. Thanks for that info. I just wanted to mention the thing it reminded me of from a previous episode.
Right. Not to mention the fact that blood thinners have risks of their own if they are
Right.
overused. So
Yeah.
we're really caught in a lot of serious binds. But I wasn't aware of that particular aspect of the kind of the medical detective work that's needed to go on to characterize liver damage, kidney damage. And also, I'm reading about this kind of cognitive impairment syndrome in post-COVID patients who don't have strokes. So what's that about? I don't know.
Yeah.
I've seen it. I've seen it, particularly in the severely ill. Actually, I had 2 or 3 patients in a row who had been intubated for the better part of 2 weeks. And then I was chatting. One of them was an engineer. Obviously, I can't get into specifics about that person, but was
Sure.
an engineer, obviously a very bright person, could not follow a conversation. This was several days after coming off the ventilator. Could not follow a very simple conversation, but was,
Wow.
obviously very highly educated, very intelligent person. And so I was chatting with some of my intensive care colleagues saying, geez, have you noticed that there's kind of behavioral and executive and cognitive changes? So behavioral meaning the way they're acting, executive meaning their appropriateness in response. For example, this particular person was very, very keen for me to adjust the television set in the room at a time when I was trying to ask questions about their clinical status. My critical care colleagues, this was a few weeks back, they'd said, no, it doesn't seem any different than what we would normally expect from people who've been intubated, but it does actually appear that this is a thing as well.
I know we've had one of our viewers actually had COVID. Ischemial, I'll ask them in chat. Ischemial, did you suffer any kind of cognitive decline while you were suffering?
Or did you get a child
well,
rash?
Because they
You
mentioned
started watching our show, so I mean that's evidence right
yeah.
there.
Because they mentioned they had the loss of smell and taste, and it was weird because everything they ate was like soggy paper. And
Especially the soggy paper.
Especially the soggy paper was like soggy paper squared.
Soggy paper squared. Yeah. So any sense from your end in terms of the clinical trials for pharmacological interventions? Anything out there that looks like signal, or is it all just noise at this point?
Okay. I am going to be uncharacteristically optimistic here, and maybe not so much about the results of the trial, but the actual cooperation. There is a massive worldwide trial called the Solidarity Trial. It spearheaded by the WHO. It is a multi-arm trial with an absolutely, truly innovative structure where they can actually add treatment arms to the trial. Normally with a trial, I'm going to test drug A versus either drug B or placebo. I've published my my trial protocol in advance. I am not going to deviate from it. If drug A is a real stinkeroo, then my trial comes to an end, and I've not really contributed much to human knowledge. But this Solidarity trial from the WHO is actually specifically designed to be able to add new treatment options in as we have data that suggests they might be helpful. There's already multiple arms to the trial, including the famous hydroxychloroquine that has been touted as a cure, unfortunately, I think far too prematurely, and remdesivir, which has been kind of the leading possible candidate, although again the jury is very much still out on it, but also other treatments as well. Canada is, as a country, taking part in this trial. The Canadian arm of it is called CATCO, and there are multiple test centers across the country which are already enrolling patients, and more gearing up, including my own hospital. And we are really truly hoping that in directly being able to compare all of the potential therapies to each other, we're going to find a winner. Right now, if I was to be forced to bet on a treatment that might be helpful, I would say most likely it's going to be convalescent sera. Because convalescent sera is basically the blood from a person who's already recovered from the infection and has those antibodies, those proteins that help fight infection. So if you can give that to a person who's continuing to fight the infection, maybe those antibodies can neutralize the virus for them and allow them to recover from their infection. This has been effective in many other types of infections over the years. We know immunoglobulins, those infection-fighting proteins for particular infections, often are very specific in terms of when you give them. So that might be a bit of a detriment to it. For example, if you were to be exposed to measles, we've got a certain window of a number of days to actually give you somebody else's measles immunoglobulin to prevent you from getting it if you've been silly and not been vaccinated yourself. So there's a very, very narrow window there. There may be a broader window in a situation like this. I certainly hope so, but that's one of the things that's going to be tested in the Solidarity study, although I don't believe the CATCO arm of that study is investigating that at present. There's also some neat stuff being done in terms of preventing the infection. The University of Manitoba, Go Bisons, is looking at prophylactic treatments as well, and that may have some benefit. Right now, the one thing we know works, well, two things we know work, is social distancing and hand washing. And if I say nothing else tonight that lands, it is we have to maintain social distancing, and we've got to be vigilant about our hygiene.
Yeah, thanks for that. So one last question then from me, because I mentioned this before the show, but would you, as I did, count somebody walking ahead of you blowing a fan at their face as a negative mask? Because I experienced that in the park today with the woman in the park with one of those little handheld fans, blowing it in her face. And all
Was it like a paper fan, or was it like
it was one of those little
battery powered,
battery powered ones, and like just pointing at her face and like showing her, I'm guessing mother, it was a family, and all I could think was I just have to somehow dodge around her and not get whatever she's breathing out blown directly on me. Like negative mask, right? That's what that is.
Wow.
Well, I just want to end this with a dumb question. I'm sorry. We've had way too much smart.
No, actually, it's really quite a smart question. There's two things at play here. Thing one is fans definitely have been implicated in spreading this infection. Okay. There's a wonderful little write-up about an outbreak in a restaurant in southern China where
I saw that.
Yeah, exactly. So the fan was literally blowing this person's virus into the table behind them. On the other hand, being outside greatly reduces the likelihood of you actually getting enough of an infectious dose. And I think that's an important thing. You're not going to get sick from one single virus entering. You have to get a certain amount of virus.
Yeah.
We don't really know with COVID how much it is. We know with SARS and MERS-CoV, it's something in the area of 1,000 virus particles. And we assume it's similar. But you're not going to get sick from breathing in a single virus. So being outdoors, having crosswinds, having some distance between you, these are going to reduce the likelihood.
Like I did.
Yes.
Okay, good. I feel better. But yeah.
Always being upwind to people.
To avoid
but I think don't do that.
Around you smoking.
Pardon me, Rob?
I said, you blowing a fan on your face would be a bit like, lighting a cigar to get the cigarette smokers away from you, to avoid the smoke.
Right. Yeah.
What are you doing? What are you doing there?
I don't.
Do you have any sense at all? These are little balls that float through the air, and you're now sucking them all in towards you and blasting them at your face.
Yeah. That is true. Yeah. I'm very often the guy who says something in real life, but this time I just didn't want to get close to them and argue about it, but damn.
Yeah, because they're going to yell at you.
Yeah, exactly.
I'm not going to break my bubble.
I thought about walking past and then turning around at a safe distance so that I could turn and run, but I just thought I'll save it for tonight, so I did. Thank you, Dr. Rose, for that. Should we wind it up? Is there anything else anybody wants to mention?
There's a question in the chat that looks very technical. It says it's from Lao Oviz. Could there be an event of neutrophil nets and inefficient effercytosis involved? Does anyone know what any of those
Lalo
words mean?
is a doctor themselves in Mexico, I believe. Hey, Lalo.
I unfortunately am not savvy enough to be on the Twitch chat. So can you read the question again?
This was a little while ago, so it might have been in reference to something that we were saying a little while ago, but it says, could there be an event of neutrophil nets and inefficient effercytosis involved?
I'm not sure that neutrophils are going to play a major role in the immune response to COVID. Neutrophils are generally one of your first line of defense type of white blood cells. Their major job is very early on in the introduction of a pathogen into your body, and they're one of the cells that will actually engulf and swallow pathogens, typically bacteria, and then inside them blast them to pieces with hydrogen peroxide and similar highly toxic particles. Usually with viruses, endocytosis like that or phagocytosis is not a major player in the immune response. And unfortunately, this seems to be the case here as well. I suspect by and large the immune response, and again, I'm not an immunologist, so if I'm wrong, you can correct me on this, but the immune response here is largely one of developing, we believe, an antibody against the spike protein. So if you ever see a diagram of the virus and it's got these little kind of mushroom-shaped things all over them, that's the spike protein. So antibodies against that spike protein appear to be important in what immunity we do develop. And the supposition is there might be a role as well for cell-mediated immunity, which means T lymphocytes, killer cells, would be involved in killing actually your own cells that are infected with the virus, as well as the virus itself. But I don't think neutrophils are a major player. I could be wrong, though. Sorry.
Okay.
Your question from Marvin61688. What are you sipping on, Greg?
I am sipping on Ruffino Orvieto. This will be my last evening to have anything for the next 4 weeks, so I apologize for being unprofessional and having a bit of vino on this, but I couldn't not.
I don't think with
not a professional meeting.
yeah, and I don't think with what's going on in the world that we can blame anybody for having a drink now and again right now.
Especially after doing what you were on service 5 weeks, 1 week off, back on for another 4 or 5.
Wow.
Mm-hmm.
Yeah.
Boom, boom, boom.
No, please enjoy, and thank you for everything you've done, and thank you for being on the show.
My pleasure.
Tons of great information. Really good. I think we're going to wrap it up. To everybody watching, we're at viraltransmissions.com. You can check out all of our past broadcasts, both in the video list here on this Twitch channel, and I try to get them up on YouTube. We also have a podcast version, which I'm a little behind on getting going. Thanks for that link, Torin. Also, for anybody interested in having some fun, we're going to play some Jackbox games starting at 8:30. I'll put a link to my Discord server so you can jump on there. We're going to play in that. And please come. You're welcome to join us. We want you to play on the Discord server. We want to get this to become a thing where lots of people come. If you don't want to play, it will be broadcasting here on the Twitch channel. So thank you and good night. Anybody else want to add anything before we go?
The link I put into the chat was penguins frolicking in a forest.
Oh, there we go. Torin
from the Oregon Zoo.
Okay, that's our positive news story, our positive penguin story. Excellent. I think I've seen that video.
Penguin PR.
That's right.
Not on my coronavirus bingo card, but the general elevation of the status of penguins culturally.
It's all a penguin plot. It's just they're killing humans in order to raise their own I don't even know what word I'm looking for. Their own PR, I guess is the right word. Yeah. Okay, thank you so much, everybody. Thank you again, Dr. Rose. And let me get
thanks so much.
Title card back.
Spread the word, not the virus.
Spread the word, not the virus. Tell everybody about the show. We want more people to watch it. Oh, sorry, Torin. Hold on. Torin wants to show off his mug. There we go.
That's all. Nothing important.
Thanks, everybody. See you on the Discord server later, hopefully. Bye.
Bye, all.